Well, hello there, and a very happy good evening to you, my friends. It is 5 o'clock. That means live at 5 in the Central Time, 6 o'clock on the East Coast, 4 o'clock in the mountains, and 3 on the West. And it is Fertility with Fink. I am Dr. Randy Fink, live from Pensacola, Florida, where we are every Tuesday evening at this time to talk about all those things that are most important to you and me, and that is us making you a family. You know what I'm saying there? Good to see everybody here tonight, as we do every Tuesday evening. I hope you are able to join. We will try to get to all your questions tonight, but meanwhile, let's say hello to all our friends joining. Is that really Amanda Hines who joined me, my old friend Amanda, and none other than Max the man in Colorado? Good evening, Max, and good evening, Amanda. Hi, ain't NBB is what that says. Ariel Eden, hey, it's good to see you as always. Marlene, thanks for being here, and hello to Sharmilla, my friend, my pregnant friend, I guess I can say right now, right? We've got a couple of different feeds. We've got Angela Sachs over here. I'm sorry, not Sachs, only one. Only one. Glimpse of Jess, it looks like that says. And so a couple of different feeds. We've got Facebook, we've got YouTube. And LinkedIn over here. We've got a couple of different Instagram feeds. Here's mine, Randy Fink MD, and this is New Life Fertilities right here on this side. If you have a question, please throw it my way, and we'll see what we can do to get your questions answered here tonight. So, hey, let me just say a very special hello to Amanda, who I haven't seen for a very long time. Amanda's my old friend from Miami with her good-for-nothing husband. And yeah, you heard me say it. What are you going to do about it? Nice to see you. Thank you for being here. Well, let's see. Oh, yes, glimpse of Jess. I'm the lady who had the giant cyst. Yes, I know who you are, my friend. Now I know. I got a glimpse. Oh, I got a glimpse of that. All right. Hey, let's boy, I'm just looking here for there we go. I got some papers. If I am not able to get to your questions here live, because sometimes they start to pile up by the end, you are absolutely free to email those questions, and that's askfertilitywithfink at firstfertility.com. Again, askfertilitywithfink at firstfertility.com. And let's take care of a couple of those questions that we had from in the week preceding here. This comes from April, and April said, my question is, I did a letrozole cycle with Minipure and triggered with Avidril. Okay, so what that means is that she did ovulation induction, and most commonly ovulation induction is when we use a pill. We use a pill to get the ovaries to release an egg, but ideally what we can do is try to get you to release more than one egg. Because, you release one egg per cycle when you're going to, you ovulate that egg. And so typically one egg every month. Well, if we can get you to release more than one egg, then we give sperm more targets to try to hit. So maybe if you can release 2 to 3 eggs in a cycle, then, in 3 months or 4 months, you've just done really another entire year's worth of trying to get pregnant. So sometimes we'll add a little injection to that. We'll add we'll add a little FSH hormone, which continues to feed the eggs and help them to grow. And that's what April did here. I got my estradiol done at 5 weeks pregnant, so it worked excellent, and it was 182. My doctor said it's completely fine because 182 is low from the letrozole, and they won't let me add estrogen. But the doctor said there's no need. I did my research, and it looks like it's very low, and that's high risk for a miscarriage. Well, so when you use letrozole, the way letrozole works is that it blocks the formation of estrogen in your body. And it does that by blocking testosterone, which is converted to estrogen. So your estradiol level will always be low when you have used Letrozole. So as a result, estradiol measurement is not an accurate measurement of anything that's useful for you there. So ideal, level is somewhere between about 200 and 600 ish, but that's in a cycle that did not use letrozole. There's really no way to say what it should be or what it needs to be because it doesn't really need to be anything, to tell you the truth, because as long as that lining got thick enough to be thick enough, at mid-cycle, then you don't have to worry about anything else. So, yep, that's good news there, April. Congratulations on your pregnancy. That is wonderful. Okay, this comes from Connor. Two questions. Does taking creatine supplements have a negative effect on IUI treatments for males? I'm not aware that it does. I haven't seen anything that says that using creatine is problematic in any way. So I think you're okay there. And does occasional recreational marijuana use have a negative effect on treatment for males? Well, to be honest, marijuana can just make sperm sluggish. It can slow down the function of sperm. It doesn't have an effect on the sperm count, but it can slow the motility in some studies. So the sperm that you produce today was manufactured in your body about 3 months ago. So if you're smoking marijuana very heavily right now, hard to know what that effect is going to be 3 months from now, but I can say that recreational marijuana can have an effect on the way the sperm move. So in general, we recommend that you don't do it when you're trying to do IUI. And then we had one other question here. This came from Renee. I've been seeing some advertisements about a test to check the vaginal microbiome for fertility. Is this a thing? So there is a very expensive test that you can do that's known as the Emma and the Alice. I have not seen data that says that this is really all that worthwhile. So certainly a healthier microbiome is a good thing to have because there can be some bacteria that are associated with creating inflammation in the uterine lining. But the truth is that there is no data to support routine testing of that microbiome or testing it in any fashion that it's associated with infertility. So in general, I do not recommend that you do that testing because I think it's not a worthwhile expenditure. So I would say probably there, Rachel, the answer is no. But what you've seen is advertising. And that's exactly what it is, because they go direct to the consumer to try to create a fear factor in you so that you push to have this test done or to have it somehow, otherwise tested. And I would say I really recommend that you don't, is my 2 cents worth there. Okay, so what else we got here? What are your thoughts on starting stims on cycle day 1 or 2 for over 40? Well, you can really start a stimulation in IVF at any time during the cycle. You can do it during the luteal phase. You can do it when you ovulate. Starting, we typically start by day 3, day 4, day 5 is usually what we do. Third day is probably optimal unless you have been on some kind of hormonal suppression beforehand. Then usually we give that about a 5-day washout and we start on day 5. I have not seen data that says that because a woman is older, that she will do better starting a stim earlier. So I don't routinely recommend that. What does it mean if you're pregnant 5 weeks and 5 days and some blood is seen on the ultrasound with the sac? So that's what's known as usually as a subchorionic hematoma. Or basically a little bruise that collects under the placenta. And what happens there is that as the placenta moves, it can shear off a little space underneath, and that space is literally a bruise like any other bruise on your body. If you got punched, it turns a bunch of different colors and ultimately it goes away. The same thing will happen most of the time with that subchorionic hematoma. There is some evidence that using a supplement known as alpha lipoic acid, and I believe that dose is, I can't remember now if it's 400 or 600 milligrams a day, can help more quickly resolve a subchorionic hematoma. So I do recommend alpha lipoic acid in your case there. So if there's a subchorionic bleed, yep, take the supplement. It can help that to resolve. Is there a way to visually tell about egg quality? Well, not really. So when we retrieve eggs and the embryologists look at them, there's some that you can look at and say, well, these are not mature eggs, or these eggs are falling apart. And so in that sense, yes, you can tell whether an egg is mature enough or whether it is, kind of degenerating. But to tell visually by looking at an egg whether it is going to have normal chromosomes, unfortunately, at this point, you can't do. Now, there is some work on the horizon that says that you may be able to use, that a laboratory can use some artificial intelligence to be able to identify which eggs may more likely create a normal embryo. But so far, that is just investigational. We haven't gotten there yet. Erica Ann says, thanks for everything you do. My pleasure. Thank you for being here on the Facebook side. Can you share your most memorable moment as a fertility doctor? Oh, gosh, you know what? I'll tell you what. That's a hard question because there are so many times when folks have just been through the ringer, when they have ridden a very uncomfortable and painful roller coaster to reach the point where finally they get pregnant, and being able to make that phone call and say, congratulations, you've done it. Unfortunately, now I don't always, I don't get to make those phone calls a lot. A lot of times it's our staff that's doing it, but I try to do it at every opportunity I can. And I'll tell you what, I can remember almost every one of those calls that I've made because it is such a special time. And just to know that I have been able to touch someone's life in such a special way is really just magical for me. And that's what I get up for in the morning and come to work. It's to meet someone who is going through a really difficult time and to know that I can do something to make their life just a little bit better. And thanks for asking that question. I sure do appreciate that, Erica. Thanks so much. Hey, let's say hi to Mohi and Mrs. Pittman. We've got Lisette has joined us here, as well as Rosa. Oh, the lovely and talented Amber Vince from Kentucky. Hello to Queen Lacito, Sarah, Mrs. Villarreal. Thank you for being here. So let's see. We got a couple of questions here. Earth Girl Peace says, I am pregnant with twins. Oh, that's awesome. Congratulations. Is it possible for twins to have different size gestational sacs at 5 weeks, but the same yolk sac size? Hypothetically, 16 millimeters in one and 9 in the other. Well, yeah, so the gestational sac, so there's a couple of different things that we see when we look with an ultrasound. So a gestational sac is the area within the uterus that contains a little fluid. And so it's really just a dark spot surrounded by a little brighter colored ring. But inside that gestational sac is a yolk sac, and the yolk sac literally looks like a wedding ring. Literally, it looks like a wedding ring. So that is clearly diagnostic of an intrauterine pregnancy. Once we get to see the heartbeats, then we know, or the heartbeat, if there's one, we know that 95% of the time those pregnancies will continue without having a problem. So that's the best odds we can hope for. The measurement of the gestational sac is probably the least reliable of those measurements as it pertains to just accuracy of ultrasound. So I wouldn't get too caught up in trying to understand what it means that there's some size discrepancy against, in the two things. As long as those yolk sacs are the same size, I think you're in pretty good shape. So that's a good thing. Congratulations. I'm so happy to hear that. Hey, to Noodles for Life, the Styles family. Hi, Sheila. And let's see, Ariel says, it has been 15 days since my last Provera and still no period. So if it's been 15 days and you haven't had a period from taking Provera, the first thing I'd want to know is, well, is there enough estrogen? Did your lining get thick enough there to give you a withdrawal bleed when you stop the progesterone? Because sometimes that's the issue. The other issue sometimes is that it may be that you just didn't absorb that oral progesterone well enough. So if you were here with me, I'd say, well, let's take a look with the ultrasound. And I'd say, okay, your lining is thick enough that you should have gotten a bleed. And if you didn't get the bleed, the next thing I do is I would give you a progesterone shot. Because with the progesterone shot, I know that progesterone is getting directly into your body, and it doesn't matter what's going on in your gut or your liver or any place else. I don't have to worry about you not absorbing the Provera, which is what happens some of the time. And then I'd see if you got a bleed. And my guess is you probably would. So as long as you have enough estrogen in your body to build up a lining, then when you take the progesterone, you should get a bleed unless you don't absorb your progesterone. So my guess is that's what's happening with you, Ariel Eden. Sharmilla says, I am 36 weeks pregnant. I wanted to get delivered by 39 weeks. Can I ask my doctor to get induced? Because I don't want to have to wait until 40 weeks. So here's the story on induction of pregnancy, induction of labor. There are some people who do not want to be pregnant anymore and want to have their babies as soon as they can. And there are other people who say, I don't want you to touch me. I don't want to do anything that's not natural. I want to go into labor on my own. Well, the truth is, we really don't want you to go past about 41 weeks of pregnancy because the placenta is an organ that ages like any other organ in our body, but it has a pretty finite lifespan, and that is ultimately roughly about 42 weeks. Some placentas get tired a little sooner than others. And if that's the case, then we start worrying about blood flow going through that placenta to your baby. If your cervix is favorable, that is to say, you're maybe already starting to get dilated, that the cervix has softened up and has started to thin its way out, then sometimes, then after 39 weeks, there is no real good advantage to staying pregnant. Sometimes we can loosen the cervix up by checking you with fingers. Other times you can help to ripen the cervix by having sex. Yes, you heard me right. Having sex does, in fact, ripen the cervix. Why is that? Well, the chemical in your body that induces labor is something that's called prostaglandin. Prostaglandin softens the cervix, makes you start to get a little crampy, and then eventually your oxytocin hormone kicks in, and that's what causes really overt actual labor. Well, prostaglandin is the same chemical that's in semen. So if you can get regular deposits of semen into the vagina, then you may very well be able to ripen your cervix and decrease the probability of having to go after your due dates. So, Sharmilla, I'd say get to work, friend, there. But if the cervix is favorable, then no advantage to being pregnant after 39 weeks. But I would say if the cervix is still really closed and long and thick and not really doing much to show that it's ready to have a baby, then sometimes inducing your labor at that point can really just increase your risk for C-section. You also, in most cases, have the opportunity to be able to say, you know what, I don't even want a labor. I want an elective C-section. And when we do elective C-sections, most commonly they are at 39 weeks. So I can't wait to see your baby, Sharmilla, because it has been a long time coming, hasn't it? Ain't NBB says, I'm on a mock cycle after a failed FET. On Monday, the ultrasound showed 6 follicles. I was only on letrozole 5 milligrams for 5 days. Do you think I can do an egg retrieval and then a biopsy? We plan to check on Wednesday and possibly trigger then with Pregnal. So, you've got so I'm a little bit confused by what you're doing when you say that mock cycle. That may mean that you're doing that in order to do a receptiva test, in order to check for endometriosis. Um, you could do, yes. Well, yeah, you could still do. So we don't want to do a receptiva at the time of an egg retrieval, but you could do a retrieval and then a biopsy a week or so later. Yes, you could. You got some good follicles there coming along because of the letrozole. So I'd say looks like you're in pretty good shape there. Let's see. Rosa says, is a natural delivery possible in women with a history of endometriosis who have an endometrioma? Yes, absolutely. So, an endometrioma is a collection of endometriosis fluid, which is really just old blood. And it's endometrioma in the ovary is what we call a chocolate cyst, because if you cut into it, it's literally brown old blood, and it looks like liquid chocolate, which kind of is gross, but it literally just looks like old blood. It has an effect on the ovary, right? It does not have an effect on the uterus or anything about delivery. So is a natural delivery possible? Absolutely, 100%. I'd say the presence of an endometrioma should not have any effect on how you deliver. Oh, let's see. Can Provera delay a period? 15 days since my last pill. My regular cycle is supposed to start tomorrow. I was put on Provera due to a thick lining at baseline. Yeah, so same situation here. My guess is that if it's been 15 days since that Provera, you just may not have absorbed it, or there may have been something else going on in terms of estrogen with your ovaries there. But it typically, yes, it can delay a period a little bit, but usually you stop the Provera and you should have your withdrawal bleed. Let's see. Hello from beautiful San Diego. Have I heard of, oh boy, have I heard of European PRP of the ovary? So, yes, and it doesn't have to be European, because platelet rich plasma is something that comes from your very own blood. So, with platelet rich plasma, we draw a tube of your blood. We separate out your body's healing components, your tissue components, which has your healing factors, your growth factors, and we can place that back into the ovary, which is said to have some benefit on egg quality. Now, here's the thing. I don't know if that was invented in Europe, but many clinics, right here in the United States, do that. It's not an uncommon thing to do, but the data is still very sketchy on whether it helps. In my opinion, it probably does help a certain cohort of people, but who those people are and what their issue is specifically is yet to be determined. So I'm familiar with, well, there's some unpublished data that shows that in the general population, it really doesn't help at all. But I would have to say, who is the group that it's helpful in? It might be people who have a normal AMH, but otherwise poor egg quality, or who have demonstrated that their eggs don't fertilize, or something like that. I think once we're able to kind of narrow that down a little better, then we will see, it probably does make a difference for some people, but in the general population, the data really isn't very good that it helps. But PRP is definitely something that can be done. Usually do it under some anesthesia. So you get some sedation, just like an egg retrieval, but instead of removing tissue like eggs and fluid from the ovary, we're placing your own healing components right directly into your ovary. And that's how that PRP works. Mrs. Pittman says, thank you, Dr. Fink. My daughter is now 7 months old. I wouldn't have her if it wasn't for you. Oh my gosh, that is the happiest news I have heard all day. So thank you so very, very much, Mrs. Pittman. Can low-dose aspirin still be effective to prevent preeclampsia if it started at 21 weeks? It's the first pregnancy, and earlier I had a subchorionic bleed. I would say yes, it's probably worth doing. I think the best data on baby aspirin to prevent hypertensive disorders of pregnancy is its use starting from the first trimester of pregnancy. But since you couldn't do it then, I'd say absolutely start it now. I'd take it if you're 21 weeks, take it through 36 weeks. But at that point, then I would want you to stop it by 36 weeks. So good deal there. So what else we got here over on New Life's Instagram here? We've got some questions. Can an unresolved cyst affect pregnancy? The last measure, the cyst was 4 centimeters after something burst. Well, it can. It depends on what kind of cyst it is. That cyst can be associated with secreting hormones. And if it's making hormones, then yeah, it can have some effect on pregnancy. Most of the time, those cysts, they're either functional cysts, which means maybe they're making hormones. They can be what's called an anovulatory follicle. So that's where you grow up a big egg, but you don't release it. Or the third issue is that sometimes there's a cyst in the ovary that is just a benign cyst that's growing there that doesn't go away. The thing that we worry about in that scenario is that if the cyst gets large enough, as the uterus grows in pregnancy, the uterus gets bigger and bigger and bigger. But when it does that, we worry about that cyst twisting on itself, and that can be a concern. Hey to Audrey Kristen. Oh my gosh, sorry, Audrey Kristen. I did it again. Let's see. Why don't some clinics check estrogen levels on the day of beta? Because it really doesn't matter. The estrogen level is not something that is associated with pregnancy outcomes at that point. Some places will check it. So where I used to work, we would check it. And why did we check it? Because the internet said, oh, people should be looking for it. And so people would call, they'd get worried about it, and they would say, what is my estrogen level? And they demand to know. And so it caused more trouble than it was worth, at least to them. In my opinion, what that was doing was that it was sowing a lot of discontent and a lot of confusion and a lot of heartache over, gosh, what's my estrogen level? Maybe it's abnormal. As long as that estrogen is normal enough to thicken up a lining at mid-cycle, then the estrogen has really done its job. Now, there is some data that says, again, roughly, in the 200 to 600 range is optimum in a non-letrozole cycle. But that doesn't mean that you should treat it for anything. That's what ideal estrogen levels are in the healthiest pregnancies. But there's no data to say that, oh, yeah, that's something that you have to treat. So that's really the reason, Angela, because because at that point, it really doesn't change anything. Let's see. I went in at 6 weeks pregnant and I got an ultrasound. The ultrasound showed I had a gestational sac, but not much else. I had lab work done to see my HCG levels, and they were around 2,000. Fear of another miscarriage. Is this indicating that? Well, so it depends on how you got pregnant. Because if you got pregnant in the normal way, then your dates may be off. And so when you have an HCG level of about 2,000, that tells me that, well, you're pretty early pregnancy. So it's really only around an HCG of, let's say 1,500 that you're able to see the pregnancy inside the uterus anyway. So you're just above that. It may be too early to be able to see what's going on there. Now, let's say that you had that gestational sac and nothing else, but your beta was 10,000. then I would say, this isn't looking promising. That may be what's called a blighted ovum, which is what we also know of as an anembryonic pregnancy. In other words, there's a little placenta there and a sac, but there was never any baby per se. That's what's known as a blighted ovum. But I would say here, Jess, if your beta was 2000 and it's still going up, and that would be the next thing I'd want to do. I'd check to see that your beta is going up. We'd like that to double in 48 hours or so, and as long as it's going up, I'd say you're still in pretty good shape. So 6 weeks ought to be the point. We ought to be able to see a fetal pole and maybe see the early heartbeat at that point. But it's always possible that the dates are wrong. It's always possible that if you did an embryo transfer, that embryo hung around on the inside for a little bit before it implanted. Or it's possible that if this was a natural cycle, that you didn't ovulate exactly when you thought you did. And so the pregnancy actually occurred at a different time than what we think. So our fingers are crossed for you, Jess. Absolutely, for sure. Audrey Kristen said, I had my second FET yesterday. Do I stop taking ashwagandha? Earliest to take home pregnancy test, the beta's in 9 days. It's a day 5 euploid embryo. So ashwagandha is actually not part of the usual supplement protocol I recommend for embryo transfer. From an evidence-based standpoint, there are 5 supplements associated with embryo transfer. Your prenatal, vitamin D, vitamin E, CoQ10, and L-arginine. Those are the 5 things that have been associated and have been shown to improve embryo transfer outcomes. Now, you had your transfer yesterday. I think you're fine to stop the ashwagandha. When is the earliest that you could expect a positive pregnancy test? Well, it's hard because those things are often they are fraught with frustration because you have to have a high enough hormone level for that test to turn positive. So if you're going to do your beta in 9 days, I'd say a day or 2 before that is worth, you could do a urine pregnancy test if you wanted to. But I'll tell you, if that pregnancy test is negative, it doesn't mean that you're not pregnant. I would still absolutely do the beta because sometimes the urine test is just not sensitive enough to pick up those low levels of beta HCG. April asks, does prostaglandin affect early pregnancy in the cervix? So prostaglandin is the chemical in your body that will make you cramp. Prostaglandin is what gives you a fever. Prostaglandin, for instance, is what happens in your body. Let's say if you get a period and you get diarrhea during your period, that is because of prostaglandin. Prostaglandin is an evil little chemical, but it's a natural and actually ultimately helpful part of our immune system. So prostaglandin can make you crampy, but generally speaking, it is not associated with anything bad happening to an early pregnancy. So people in early pregnancy say, can I have sex? And the answer is, yes, you can. Yes, you can. As long as you're not bleeding, as long as there's not some history along with that to suggest that there's some reason that you shouldn't. Sex and a prostaglandin deposition into the vagina is a-okay early on in pregnancy. Mednicare. Hello, Erica Lissa. Erica Ilissa. I think I said it right. Noodles for Life. Who I got to tell you, I really like the name there. Can I skip doxycycline for a medicated FET? It seems to have some negative side effects. Well, it's part of an immune protocol. And the reason that we give you doxycycline is because even though when you have an embryo transfer, we're doing it under clean conditions. We're trying not to touch that transfer catheter to the walls of the vagina or to the bacteria in the vagina or any place else outside of the vagina, we're still taking that otherwise sterile instrument and placing it into a sterile area. And if that little implement is contaminated with any bacteria, which is highly probable because we are dragging it through the vagina, you run the risk of transmitting that bacteria up into the uterine cavity. And that can cause something called endometritis. So I do generally recommend doxycycline, but it's not a deal breaker. If you can't tolerate it, there may be some other antibiotics that we can use. We can use erythromycin or azithromax. But if for whatever reason you don't want to do it, then yeah, you certainly don't have to. It is not a deal breaker. Let's see, waiting on PGTA results. This comes from Sarah, but if a day 5 4AB embryo and a day 6 5AA both came back euploid, which would be prioritized for transfer? The answer to that would be the 5AA. So, oh, I see. No, actually, it's a day 5 AB or a day 6 AA. So day 5 and day 6 embryos typically perform about the same. If it's a day 7 embryo, those don't always do as well, although if it's a euploid embryo, that's still a very good thing. But the better graded embryo there would be the AA embryo. And so I would say if those both came back euploid, I would do that day 6 5AA because we're picking the one that just kind of looks the prettiest and looks the best. And that's kind of what the embryo grading does for you there. Now, the other consideration, since you are waiting for the PGT results, is what's the gender? Because if one of them is a male and one's a female, and you were hoping to have one or the other, that may make your choice. But I would say once you get an embryo that says it's euploid, that says it's chromosomally normal, then the grading really typically doesn't matter so much, So good deal, Sarah. We will keep our fingers crossed for you, friend, for sure. Let's see. Hi to Jackie. And here's, oh, I appreciate you. Oh, thank you so much. I felt I'm being led to negative thoughts and so much stress and heartache. Naturally conceived this time. Oh, that is wonderful. I'm so glad. The process really is full of stress and heartache. And what kind of effect do you think that stress has on your body? Well, there's a couple of different ways to look at that. There are people who are living on the streets, who are using drugs, who are accidentally getting pregnant behind the 7-Eleven in the middle of the night, and they don't even remember it. And maybe they go through their pregnancies on the streets. That's a significant kind of stress, because there's no roof over their head. Maybe they're using substances which are, causing bigger issues with the growth of the baby. But stress, the kind of stress, and people get nomadic tribes on the plains of Africa. They're worried about the lion jumping out from the tree line and attacking them or stealing their baby. So these are very stressful things. But stress is certainly in our lives. When we're under stress, our cortisol levels get high, and high cortisol levels. Well, what effect does that have on pregnancies? Well, that means that your adrenal gland is working overtime, and yeah, it can have some effect. So that's one of the reasons that I say, well, gosh, if you're dealing with issues like depression and anxiety, most of the medications used for depression, for instance, the SSRIs, are pretty well studied in pregnancy and have been shown to be safe. So I feel like it is that the risk, that the benefit exceeds the risk for using those medications, because untreated depression and anxiety in pregnancy may cause more problem than any theoretical concern that comes with a that comes with the medication. So, yes, stress does affect us, and especially this process of fertility and getting pregnant. It's a big deal, and a lot of people don't realize that. And listen to me telling you, because I think you guys know better than anybody that people say, oh, just quit, thinking about it, and then you'll get pregnant. Stop worrying about it, and oh, you'll get pregnant. As soon as you quit focusing on it, you'll get pregnant. Well, that's a really insensitive thing to say, in my opinion, because people, I don't think they mean harm by saying that. They're trying to soothe you in some way, but really, it doesn't address the heart of the matter, which is that this is a process that you're going through that hopefully results in a happy ending. And so to say, oh, ignore that process, forget about it, is like saying, oh, your process isn't important. And we know this may be one of the most important processes of our lives. And that's why I say, and I will say it again here at the end of this broadcast, that this is not the book of your life. This is not the story of your days. It ain't your novel. This is just a chapter, and all we're doing is trying to rewrite it. So, Jess, God bless you. Congratulations. My fingers are crossed. Anything I can do for you, please let me know. Let's see what else we have here. Another question. Younger eggs frozen in an old clinic, currently a patient in a new clinic. Would you ship the eggs from the old one to the new one, or ship embryos, or go to the old clinic not to disturb the eggs? Oh, so that's a really good question. It some of that depends on what they do with your eggs at the old clinic, because there are many places that don't actually store your material on site, that they ship them off to long-term storage. And if that's the case, then what you're doing there is that you're taking the embryos from one out of long-term storage, shipping them to a new place, who may then ship them back to long-term storage. So I don't think it makes a lot of sense to do that. I would say that your eggs are fine to be kept in the old place until you're ready to use them. As long as you're comfortable with that place, and you feel safe and secure with how they're stored, I would leave them where they are until you're ready to do something with them. And if you like your new clinic, then if you're ready to fertilize those eggs, ship them at that point. Let the new clinic do the fertilization, and then go from there. So shipping embryos or eggs is generally a pretty safe thing to do. There are a few companies out there that's really all they do, because you don't just want to leave that to FedEx, and you don't want to leave that to you just kind of don't. I keep kicking my light here. Sorry about that. There we go. You don't want to just leave that to chance. So these companies that do it, they typically do it very well. So I think you can feel pretty safe there about that. Hi to Linda. Thank you for being here. Anne Marie has joined. Anne Marie is our wonderful ultrasound tech here at New Life Fertility, one of our fabulous ultrasound techs at New Life Fertility, and a wonderful person to have on your side. Thank you for being here, Anne Marie. Hello to Zenaida in Miami. Thank you as always for being here. What is your take on stem cells to improve egg quality? So there again, so stem cells are a little different. Stem cells are the cells in your body. This is different from PRP. So we talked about platelet-rich plasma. And platelet-rich plasma is where you're taking a tube of your blood and you're putting your healing components, your tissue factors, your growth factors into your ovaries in an effort to improve egg quality. Using stem cells are little cells that are a part of our body. They're often derived from fat. So sometimes they'll take some fat from around the belly or around your butt, and they will separate out what are called the stem cells. And these stem cells are basically a plain vanilla cell that can become any flavor under the rainbow. Does that make sense? They're a generic cell that can become any other type of cell in your body. And so they use stem cells to try to treat different things. So you may see an injured joint, like your knee, you had torn cartilage in your knee. Well, they can inject some stem cells in there, and sometimes those stem cells can absolutely just heal that torn cartilage without surgery. So, they're finding all kinds of newer uses for stem cells in this day and age, but, it's still considered experimental. So, stem cells, I don't know that they are legal in the United States to use, but there are some places in Mexico that do that. And I am still a little leery of going to Mexico for fertility treatment. Not that there's anything wrong with it. In fact, a dear friend of mine is currently pregnant, early pregnancy from a treatment that she did in Mexico. So, not that there's anything bad about it. It worries me. I feel a little leery about it, and the science is evolving as it pertains to stem cells. So what you kind of want to be careful of in this scenario is that you want to just make sure that there's not some place or some clinic or some doctor who is interested in extracting money from you in exchange for hope. I always say hope is not a strategy. Hope is an important part of what we do because your heart speaks very loudly to the rest of your body. Your brain talks very loudly. How you feel speaks very loudly. And hope is an important thing, but it should not be the sole part of your plan, because base your decisions on science, base your decisions on evidence, because there are some things that are good ideas that just don't always pan out. And I would say, stem cells we're getting more information about them, so maybe it's helpful, but just do your research. A special hello here also to Jess Ziv, who is our wonderful nurse practitioner in our Dothan office. So here in New Life Fertility, we have an office in Pensacola, we have an office in Dothan, Alabama, in Mobile, Alabama, in Tallahassee, Florida, and in Panama City, Florida. And so thank you so much for being here and doing what you do so well, Miss Jess. Can you do, let's see, Angela asked, can you do it pro the same day of your egg retrieval? I'm not sure what you are asking there. Can you do it pro the same day of your egg retrieval? I think you meant, I'm not sure what you're asking about there, what you can do the same day of your egg retrieval. Well, you can do a hysteroscopy the same day of your egg retrieval. You can do an endometrial biopsy the same day of your egg retrieval. And those are good things. You're not supposed to do a receptiva on the same day. So it depends on what you mean, Angela, and I'm sorry, I'm not sure what you're asking. Zenny says, we're both wearing green shirts. Yes, indeed, but I am having a bad hair day, so I don't know about you, but maybe a green shirt distracts from the bad hair. If sex can ripen the cervix towards the end of pregnancy, can it have the same effect in early pregnancy and cause the cervix to soften so early on? Well, that's a good question there too, and the answer is probably not really, because there are the prostaglandin levels. We talked about prostaglandin affecting the cervix and starting to ripen the cervix, and that prostaglandin coming from semen being deposited in the vagina. The answer there is that there's your prostaglandin levels are starting to go up as you approach the time of delivery. So the prostaglandin that comes from semen is really just prostaglandin in excess of the prostaglandin that your body is naturally making. So earlier on in pregnancy, you should not be making that much prostaglandin. But that's one of the reasons why I say, well, gosh, if you're having issues, with preterm labor, for example, then we tell people don't have sex, don't get semen in there, because that can increase the kind of cramps and contractions that you have. Hi to Christina. Thank you for being here. Jay Bizzle, is that the real Jay Bizzle? Hello, Jay Bizzle. Midgie56. Let's see. Earth Girl Peace, thank you so much. We look forward to seeing you every week. I'm so glad to hear that. And I have to tell you that I look forward to being here every week as well, because this is the happy place. Going back to Erica, who asked me earlier on, what's the most memorable moment as a fertility doctor? Uh, the the part of this that I just love is really being able to touch people's lives, and I don't mean physically necessarily, even though, gosh, as a fertility gynecologist, yeah, we do that too. But you know. Um, it's about sharing some part of the heart, the soul, the spirit, as well as the knowledge. Um, Caring for others comes in ways that are more than just knowing what the data says and the research says, and just knowing that I've affected somebody's life in a positive way really means something to me. Um, I still hear from people whose babies I delivered, 20 plus years ago. And yeah, that makes me feel old. Thank you very much. But the fact that they still remember me, that they know my name, that they still think of me, and enough to send a card every year, or to say, gosh, you saved us, back then. It really means the world. So for you to say that you look forward to seeing me is more meaningful than my friend. Thank you very much. Angela's clarified here. It's PRP, not pro. Can you do PRP at the time of an egg retrieval? The answer is yes, you can. In fact, that's not an unreasonable time to do it, because you're already under anesthesia at that time. My ear thing here is just going crazy, so I'm going to take it out. It's falling all over the place. That is a good time to do PRP, but it's not for that cycle. It's not for that time when you are, for the eggs that you're retrieving. That it would be for a future cycle. So I would say, yeah, it's a good time to do it, but not for then. Let's see. We've got a few more minutes here on our show. So if you have other questions, throw them this way. And if you don't feel like asking aloud here with the chat, you can easily send an email to askfertilitywithfink@firstfertility.com. So I got another question that was said here, and this was emailed in, and it says, please don't mention my name. I hate to ask, but since you were talking about sex, what about orgasm? What happens during orgasm, and does that, or can that cause preterm labor? Well, so an orgasm is the rhythmic contraction of the pelvic floor musculature and the uterus. Believe it or not, it doesn't have any adverse effect on pregnancy. And in fact, I've seen some studies, not real strong studies, but I like the way they think, that shows that having an orgasm prior to doing something like an insemination is a good thing, because it's significantly increasing the blood flow to the uterus. And so I always say that sexual intimacy is a very important part of our relationships, and especially as we approach the stress associated with trying to get pregnant. That stress can become overwhelming, as you know. And so intimacy with the one you love may be a very good stress reliever. So I would say, yes, you're in a pretty good place to do that. And no, I've never seen anything that says that we are causing any problems by doing so. So again, if you have questions for next week, feel free to get them to us before the show starts at askfertilitywithfink@firstfertility.com. We're going to start to wrap up the show here tonight. It's been so nice to see all of you, as always. I'm here every Tuesday evening at 5 o'clock Central Time, which means 6 on the East Coast, 4 o'clock in the mountains, and 3 on the West Coast. What did I say before? Do you remember? Fertility business here. This is not the book of your life. This is just a chapter. And what are we here to do? We are here to rewrite it together. Additionally, important words of advice: every step forward with kindness, every step forward with love, and every step forward knowing that tomorrow is a new day full of all new adventures and all new hopes and dreams, right? Thanks so much for being here. Dr. Randy Fink in Pensacola, good night. Bye.